I'm Devin Golden, and welcome to the next edition of the Mesothelioma Guide podcast. If you've listened to our podcast before, you've heard interviews from doctors, researchers, and medical experts talking about the efforts to find a cure for mesothelioma, a rare cancer caused by exposure to asbestos, or at least a way to manage the cancer, stopping its rapid growth and holding it at bay for long enough to live one's life naturally rather than having it cut short due to this cancer. That's the end goal of mesothelioma research. We've talked quite a lot about it in past episodes. On this episode, we're going to do something a little bit different. We're going to talk about a different aspect of cancer treatment, although an aspect that is extremely important and deserves its own discussion, and that topic is quality of life. On the phone with me today, I have Dr. Lara Traeger, a clinical psychologist at Massachusetts General Hospital. She is leading research on a very unique and interesting study involving mesothelioma and lung cancer patients. Massachusetts General has a Center for Thoracic Cancers that handles treatment of mesothelioma and lung cancer, including surgery, chemotherapy, radiation, and clinical trials. The hospital also focuses on the mental health side of cancer treatment, which is why I've invited Dr. Traeger to talk today. Dr. Traeger, thank you for joining me and taking some time to talk about your project and quality of life in general for people struggling with mesothelioma. And I do hope that I pronounced your last name correctly.
You pronounced it perfectly. And thank you for inviting me to do this. I'm really happy to be here.
Awesome. So we can kind of jump very general. The term quality of life, it can mean quite a lot. It's a very wide-ranging term. But if I could wrap it up into one word, and you tell me if you think that there's a different word you'd choose, I would say happiness. Or you could say, or comfort. But, happiness is, I think, a very good barometer of quality of life. And let me know if you think that's right. But, I mean, you can measure happiness in a lot of ways, and it can be affected by a lot of aspects. And sometimes the quality of life is viewed separately from actual treatment or the therapy that a patient receives. But they aren't mutually exclusive, right? Your quality of life can be affected by how your body responds to treatment, how effective the treatment is, whether your prognosis improves or worsens. But you tell me, how would you define quality of life?
So I would probably, if you had to ask me to pick one word to define it, it would be well-being.
Well-being.
I think happiness is a great feeling to have, but it's not everyone's, ultimate life goal to achieve happiness. So quality of life is an important concept for any of us to consider, and it focuses on, like I said, our general sense of well-being, our sense that we're leading a good life or a life that's at least consistent with what matters to us. So that's a little bit different than happiness, but let me go further into it. Some of the key areas of life that could make up a person's well-being would be things like emotional health, physical health, like you had mentioned, but even also other things like spiritual well-being, our sense of connectedness to the people around us, and even our ability just to do the things that we need to do or want to do from day to day. So as you can see, the concept of quality of life does extend beyond the idea of happiness and really does depend on a person's view of themselves and of the world around them. So when we measure quality of life in our research, we ask specific questions about how a person is doing, how they're feeling in some of these different domains. But even outside of research, just in our own families, even a general question like, how has life been lately, can start an important conversation about quality of life that goes beyond a person's specific cancer type or their stage or their laundry list of symptoms and side effects that they may be experiencing.
Okay. You've touched on this a little bit, and I know we talked about, there's the physical aspect, the emotional and mental aspect, but those two can be connected, especially for people who are going through, a cancer diagnosis and cancer treatment. As an expert, explain how are those two things linked, and how do you have to worry about both because they can each affect each other?
Right. That's actually a really good point, is that how we feel physically can impact how we feel emotionally, and how we feel emotionally can impact how we feel physically. So one example of that could be something like pain, which is a common experience for people going through cancer care. And so, for instance, you might wake up with some physical pain that is, a measurable amount of pain, and that can put you into a negative mood. And that negative mood, in turn, can lead you to start thinking pretty negatively about yourself or about the world around you. It also can impact your interactions with your loved ones, because if you're in a negative mood, you might be more likely to do something like isolate yourself to avoid people or avoid burdening them, or maybe even lashing out at people because you're just feeling more irritable. And so you can start to see how, just feeling something physically can affect us, how we think, how we feel, and also how we behave and interact with other people. And that kind of creates what we call sort of a cycle of thoughts, feelings, and behaviors where, the more you might be isolating or lashing out, that might further impact how you're thinking about yourself in negative terms. And sometimes also what can happen with, pain or any symptom like that is that it, just further can give you the sense that you can't do the things that you normally would want to do, but it also might stop you from trying. So pain or something like fatigue can cause you maybe to limit your physical activity, which might actually cause you to feel even more fatigue, or the sense of tightening around your pain, or getting tense around your pain, or tensing up your muscles, which can actually end up making you feel worse. So the way we kind of address that is helping people see that cycle and really understanding what are ways to break the cycle and to feel more positive about how you can be coping with that pain or that fatigue or whatever it is, to create a cycle that actually can veer towards the positive.
A lot of focus is given to quality of life during treatment, during cancer treatment. The side effects of chemotherapy, for instance, can decrease a person's quality of life, especially because the side effects of chemotherapy can be so uncomfortable. And so many people know all about, the nausea, just the feeling of feeling weak and tired. Some patients get a lot of end-of-life pain relief care to increase their quality of life in their final remaining days or weeks. Those are just a few of the treatment-related aspects which can be adjusted to improve the physical side. What can you do otherwise to help a patient's quality of life aside from specific treatment stuff? And you kind of already have talked a little bit about this.
Well, I will go back to that because it's a great question. There are a number of other things we can do to help someone improve their quality of life, or to maintain a quality of life that's acceptable to them. And to go back to the example of pain, what you just said is a really great example of this. I'll use it again, maybe in a different way than I just did. But you mentioned that patients can get, end-of-life pain relief care. And pain medications are an important part of pain management. They're kind of the gold standard for pain management in people with chronic cancer pain. But they're designed to reduce pain, not to eliminate it. And many people, even when you're taking pain medications, they still have some residual pain. And it's still something you kind of have to stay on top of. So in my field, in psychology, in the psychology of cancer care, what we might first do is help people put in real terms how their pain affects the areas of quality of life that are important to them. So in real terms, for instance, does it stop them from taking their dog for a walk? Does it stop them from working on a household project? That, putting it in those terms, gives us a barometer. Pain is very subjective. It's hard to measure. And so if you can say to your cancer care team, this week it stopped me from taking my beloved dog for a walk. Maybe this following week, I've actually been able to take my dog for a walk. This helps people measure pain in a real way and help understand what might be the goals of pain management. Once we do something like that, we can help people identify what about that situation is under their control and what about that situation is just not under their control. So there is some degree of pain management that is under our control, and there is some degree of pain that just simply isn't. And being realistic about that is a really important first step, because we can use that information to help people select coping strategies that match, right? Exactly. So when you have something controllable about pain, there's some degree of pain that is controllable with medications. You can take steps, and we can help people take steps like helping people take their medications as prescribed, managing the side effects of medications. There's a lot of side effects of pain meds, or even helping people advocate for themselves, talking with their doctors about changing their medication dose or schedule to better treat their pain. But on the other side of that, I think, is some of the coping strategies that we just don't talk about as much. And those are, strategies for and, helping us navigate the uncontrollable aspects of what bothers us, like pain. In other words, we can help patients practice ways to take care of themselves and have meaningful experiences each day, even when a part of their pain is not going away. So taking what we know they love about what they do from day to day and figuring out how to either do those things or cope with the loss of not being able to do them. That's a really important concept for us, because it just helps us, because it helps people take action when change is possible, but to step back and take care of themselves when some acceptance is called for. Does that make sense?
Absolutely. And you said the word that I was going to bring up next, which is the word that we
Oh.
hear so much in cancer treatment and cancer diagnosis, which is coping. That's the word that we hear so much about, right? That's the mental side of things with like everyone is coping with their diagnosis. And when you succeed in doing so, and when you're successfully coping with it and you have those kind of strategies to help you cope with it, your quality of life, at least from the mental side, does improve. And you talked about coping with the stuff we can't control. And that's, I think, a really important part of that. But I imagine it does change, like the specifics of what that means changes for every single individual, right? It's kind of like what they say, like when you go to therapy for mental health, no two therapy sessions ever in the whole history of the universe have been the exact same, because everyone is so different and our minds are so different. I mean, does that sound, I mean, is that also a challenge for you as an expert? Because like there's just no one solution for this.
I don't see it as a problem. I see it as an opportunity, really, because what we're talking about is a model, right? That there is space for two types of coping. One is that action-oriented, problem-solving, do something about it kind of coping. And the other one is the take a step back, take care of ourselves, accept what we can't change type of coping. And so helping people find the balance between those is important. And like you said, everyone is different. So I think oftentimes what we do and what, the program that we're here to talk about does is help people first start off and think about, what type of coper are you? When something is going on, do you tend to gravitate towards trying to do something about it, taking an action? Do you tend to gravitate towards, taking a seat and, taking care of yourself and calming and soothing yourself? Sometimes that balance is where it needs to be. And other times it helps to think about shifting it to make sure that you're using those action-oriented strategies for what's changeable, and you're using the more emotion-focused or acceptance-focused strategies for what isn't changeable. If there is a mismatch, the issue is that when you take action, it's kind of like banging your head against a wall that doesn't move. And then when you take a seat during, in the face of something that could be changed, it's a little bit like, I wouldn't say giving up, it's just a little bit like taking a seat when you could be standing.
Exactly.
And so, helping people really see things as they are and acknowledging what is changeable and what isn't, and going from there is a really important first step. So that at the end of the day, whether you're focusing or you're finding that balance, maybe there's more action or more emotion focused coping on any given day, they're both, in a sense, active, right? And at the end of the day, you can say, I am doing the best that I can with what I have.
I love your answer, because I can relate to it, as I'm someone who tries to change things that can't be changed. So I try and take action on things I can't change, and I end up just going around in circles and wasting the day away in my head. So I love that answer. It's so on point. Let's talk about the specific project and the clinical study that you are leading at Massachusetts General Hospital and that you're part of. Because it's different than most quality of life studies. Like I mentioned earlier, a lot of focus is given to quality of life during cancer treatment, right? So like, how do we increase a person's quality of life when they're getting chemotherapy, when they're going through those side effects? Your study focuses on quality of life after treatment ends. And that's why it's so unique, because it really is filling a void of, I think, something for a lot of people who complete treatment and there's just still a lot of issues that they're having, psychological and even physical, across the board. So, can you explain a little more about the study, how it works, and the inspiration behind it?
Sure, I'd be happy to do that. So you mentioned the reality, which is that a lot of our studies for patients with serious cancers focus on what's going on for that person during treatment and how to help them cope with side effects and symptoms that they're experiencing. And like you said, this study actually focuses on the period after treatment ends for people who are being treated with curative intent. So there, you might have the assumption that after treatment is over, it's a celebration and life goes back to the way it was. And that is maybe the case sometimes or to some degree, but there are a lot of unexpected challenges that can happen after treatment is over. And our study is designed to help people navigate those unexpected challenges. The way we put this together is because we actually spoke with patients who were being treated for mesothelioma or lung cancer with curative intent just towards the end of their treatment. And people, had some fears about what life might be like, but they also had some relief that they were getting to the end of treatment and they were feeling optimistic about getting back to the life that they wanted to get back to. We then spoke with people a few months out. And a lot of times what people were talking about was these really wonderful coping strategies that emerged to face some things that were unexpected, but also there were some significant challenges. And we thought to ourselves, we can help people take those coping skills that they have, help them strengthen them, and maybe even add to their toolbox, because some of the things they were facing were really unique. So for instance, the idea of uncertainty, how to cope with uncertainty. In terms of what the future holds. Will the symptoms that I have continue? What is my, life going to look like? What is life going to look like for my family? Will I get sick again? Will I need treatment again? When would that happen? Changes in relationships. So, maybe people figured that after cancer treatment was over, life would kind of go back to the way it was. And it just, sometimes relationships don't always go back to the way they were. And then we have a couple of more areas that we focus on, but I'll just get back to the design of the study, and then maybe we can talk a little bit more about what our sessions hold. But what we do is kind of start to meet with people right at the end of treatment and just talk openly about what their goals are, what their hopes are, what their expectations are for life after treatment. And then they finish treatment and we give them a couple of months to kind of regain their footing, and we get back together with them about 6 weeks after they finish treatment. And really then we start the program and we give 4 more sessions where we go over, how has life been? You had these goals at the end of treatment. What are things like now? And sometimes people have been flexible in sort of changing their goals if the goals weren't working out, or sometimes it can be pretty challenging when it's hard to change the expectations and goals that you had set. So we focus on all of that. And the inspiration actually was a patient. There was a man who was treated at the Mass General by my oncologist colleague, Jennifer Temmel, who's another co-investigator on this study. And he was the inspiration in that he was someone who at the end of treatment felt like, or maybe even during treatment, I don't need support, I don't need help, I'm doing okay. And his oncologist said to him, you know what, why don't you just meet with one of our psychologists and just see what it's like? And he ended up forming this really helpful, productive relationship with one of the psychologists on our team. And, that relationship continued through the end of his treatment and after, because he was somebody who realized there are some unexpected challenges that happen after treatment is over, and I do need some support around this. So he turned around and he said to us, and his psychologist was named Joe. He said, how can we bottle Joe? How can we bottle what Joe and I did together and offer this to all patients, even those who say to their oncologist, I don't need the help. What do we do to make this accessible to people, to destigmatize it, and to focus on the things that matter? And so we answered this man. We said, you know what, let's sit down and make that program. And we did.
And so you said you start at 6 weeks out and there's 4 sessions.
Yep.
So it would end, I guess it was once every couple of weeks. So it would end when you get to 14 weeks out of post-treatment or somewhere around there. Is
Right.
Is that correct? I want to make sure I had that timeline correct.
Sure. So we meet initially with people right at the end of treatment to
Yes.
capture them during that very unique time and learn what they're hoping and expecting. And then 6 weeks later, like we said, we have 4 more sessions where we check in with people. How are things going? And celebrate the things that are going well and address the things that aren't going as well. So and so the sessions can be once a week or once every other week. We really try to keep them being done regularly, but we have some flexibility because we know people are busy.
For the study itself and for measuring the impact of the study, I know that you have like there's a spot where you say, okay, we're going to measure how well and like the effects of the study at this 14-week period. But in theory, and I'm not sure if this has already been talked about and agreed on, or if this is just an idea, this could just be an ongoing for as long as the patient wants, as long as it's helpful to them, I guess, in theory, correct? I mean, it doesn't have to stop at 14 weeks. I know that the 14 weeks is more so we get a measurement of what the effects are.
Oh, I see. So this type of treatment is very much a skills-based approach. So the sessions are very active where we're introducing and practicing specific set of skills.
Okay.
And so these types of programs do tend to be short-term and
Okay.
structured. And so it is actually a 4 to 5 session program. But from there, if people do feel like that kind of support is helpful, then we would encourage them to continue this kind of work outside of the study, which is certainly possible. And then, of course, there are some people who are just going to want some more flexible or open-ended type of support, right? So a supportive counseling approach might be helpful to them. And then there are others who might be looking for something like peer group support to meet other people who might be going through the same thing. So there are a lot of options for people to consider after they've done our program.
And because you've destigmatized the idea of going through therapy and going through some sort of counseling, I would hope that it would result in people being more open to, when they finish the program, saying, okay, I would love to set up an appointment with, for counseling, or I would love to set up an appointment and join a peer group.
Right, exactly. That's a really good point, because participating in this kind of program is not us telling a person, hey, you're failing at coping and you need help. It's really about saying anybody can benefit from this, just an opportunity to talk about what's challenging and shore up our coping skills. And if that is helpful in destigmatizing this kind of support or mental health care, that would be phenomenal.
The study is explicitly for people specifically for people with mesothelioma and lung cancer. So you're focusing on a small group of the cancer community. And for Mesothelioma Guide, obviously our number one purpose is to inform people with mesothelioma and the loved ones of mesothelioma patients with treatment options, support options, such as this study at Massachusetts General. Why was this group selected? I guess because it's such a small. I mean, mesothelioma is a very rare cancer.
That's a great question. So we chose to include people with mesothelioma because they also share some things in common in terms of their cancer journey with other types of cancers too, including ones like lung cancer, which we're including in our program, or head and neck cancers. But these are really cancers that present patients and their families with unique challenges. So there are a number of existing studies that test programs to enhance quality of life for people with early stage cancers like breast cancer and other types of cancers that have low rates of recurring or returning. We chose to work with people who've been treated for mesothelioma and with lung cancer because virtually there have been no or very few, I can count them on my hand, studies of programs to enhance quality of life for people who are completing treatment for those. And that's important work that we need to do. We need to figure out whether our ideas hold, right? Can we improve quality of life for people who have finished treatment but are having to cope with uncertainty, and a significant amount of it, about their health and what the future may hold? And I think there are ways that we can be successful in that. And I hope our study can show that, to be supportive to people who are facing mesothelioma and some related cancers.
You mentioned expectations earlier in a conversation with me, what people are expecting and what their goals are. Is expectations and kind of helping people cope with expectations, like if there was like a number one goal for this study, is that like the one thing you're hoping to measure, or is there something else, or maybe there's nothing at all really specific number one, and there's just a lot of different aspects to this?
You're right. So one of the things, just to mention something before, you'd mentioned about what we're hoping to accomplish, and we really are hoping to, at this early stage, work with our study participants, who we're very grateful for when they enroll in our study, to understand, does this program meet their needs and their expectations? So that word expectation is really popular in multiple senses of the word. But you're right. So what we do focus on is people's hopes and expectations for life after treatment. And it's not so much about, dashing those hopes and dreams, or helping them cope with disappointment per se, but it's really, I guess, if we were to think about what this program aims to do, is to help people increase their flexibility in their thinking around how they can meet those goals that are important to them in meaningful ways. So I would say that's really the crux of it.
Okay. The transition after cancer treatment is scary because, and you said this to me earlier, and I found your description such like a flawless way of explaining it. People get this support from their medical team for weeks, sometimes months, from your nurse, from your oncologist. You're constantly getting support, guidance, recommendations, care, and just a person to talk to. And then all of a sudden, and as you described it, your treatment ends and it's like you're falling off a cliff of support. And I'm using your words on that because I think that that's just absolutely perfect. It's like falling off a cliff. You don't have that same net of support with you. And so this program, I imagine that one of the aspects of this program is going to approach that, right? Like you mentioned, your relationships change. And one of the things is that you really don't have, those same medical relationships kind of helping you through cancer treatment. So when cancer treatment ends, it's like, okay, my routine is off. The people who were such a big part of my life are no longer here. That's obviously got to be a struggle for people.
Yeah, those are all, it's a helpful way of thinking about it, because the end of treatment really is an interesting point in time. And that's why we focus on that in this program. When people finish treatment, there's so many different feelings you can have. It can be a relief. It can be daunting. It can be both at the same time. You can be holding very different feelings all at the same time. During cancer treatment, I know you mentioned this, but for some people, there is that sense of security and knowing you have your cancer care team's eyes on you regularly. And for those of us who like to take action and have some organization in our lives, there's a sense of taking action because you have a treatment plan to follow. So that all changes when treatment is over. So at that point, we really are focusing on helping people learn and practice strategies for managing their worries, particularly during the times right before the next scan, or when you're waiting for those scan results, which can be tough times. Or it's just on an average day when you are maybe finding yourself involuntarily kind of checking your body for signs of cancer recurrence, and you see something that you hadn't seen before, what you do with that worry that day. So we really help people practice strategies for managing worry, for practicing how to access the kind of support that they need, for developing a new kind of relationship with our cancer care team now that they're not seeing them regularly every couple of weeks.
So I'll ask a couple of specific questions about the study, just so that all of our listeners who might be interested can have as much information as possible. Have you started enrolling patients? And have you already started? Okay, awesome. I don't need to know obviously the specifics. I'll be looking forward to the results, but that's awesome. That's awesome that you already have people kind of going through the program.
Yeah.
How many patients are you hoping for? Obviously you would love to have as many as possible as everyone goes through, the treatment program at Mass General, but how many do you want specifically for the study, in your opinion, to get like enough of a sample size to make a determination about the effectiveness?
So we are following a pretty evidence-based route to getting to the goal, which is a strong, useful program that can be delivered, delivered widely. So we're starting off small. So we are aiming to enroll for this phase of the study 45 people. And that's enough that we need to determine that the study is feasible, that it's possible for people to participate and to complete it, and also that it's acceptable, that the participants think it's useful to them and that they enjoyed being a part of it and felt like they learned something.
Okay.
And then from there, we then move into testing and ensuring that it actually does improve quality of life like we're hoping it does.
Are you actively seeking, or maybe not actively, but are you allowing participation from people who've had treatment at other hospitals, or is it only patients who've been treated at Massachusetts General?
Right now, we are only enrolling patients at Massachusetts General, and one of the factors for that is, one, because it's a small study, and two, oftentimes that decision is based on our limited funding. So that's our situation right now. But hopefully we can widen this. So after we're done with this small phase, that we can obtain funding to help make this study more accessible to people outside of our hospital. And I didn't mention this before, but one of the ways that we'll be able to do that, to be able to offer this to people more widely outside of our hospital system, is because all of the sessions can be delivered via telehealth, via video conference. So we've set it up in a way that you don't have to come into the hospital to participate in the program.
Awesome. And you said that this is the first phase, so it's 45 participants, and there may be future phases where maybe there's a different aspect or there's a slight variation to the specifics of the study. A lot of clinical trials, and they're medical ones, they have to go through the FDA approval process. That's why there's like 3 different phases. But I imagine this doesn't really fall within FDA's approval. Maybe tell me if I'm wrong on that. This is more just, we want to figure out a very effective program for the patients that we have, right? So like it's almost, it's not really like there's no oversight from the FDA. It's just, this is just like a self-oversight type of thing that we want to make sure that we have the best possible. So we're going to go through multiple different phases to make sure that we're considering all options. Awesome.
Yeah, so this is not a drug trial, but in our type of studies, which we call behavioral trials, we also have a phased approach, which is somewhat similar for similar reasons, in that we want to make sure that the program is doable, is acceptable to the people we want to work with, that they think it's necessary, and that it actually does what it says it's going to do without any side effects. Or not without any side effects, because that doesn't really relate to a behavioral study, but basically that we can achieve improvements in quality of life.
Of course. It seems like you and Massachusetts General are forming a new standard for helping cancer patients with their post-treatment quality of life. And you've already talked about this, but this would be, I think, a great question to kind of wrap everything up. What do you hope to be the outcome for this, say, 5 to 10 years from now?
Generally speaking, in the next 5 to 10 years, I hope that quality of life remains alongside length of life as a critical element in cancer care, and this program is a part of that. I also hope that we continue to identify creative ways to support people who are finishing treatment, as that is continuing on their cancer care journey.
Is there anything additional that we have not discussed about this specific study, about the topic of quality of life, that you would like to touch on?
I think we've hit on all the points, and I'm really grateful for the opportunity to discuss them today, because it's one of my favorite things to talk about.
Dr. Traeger, thank you so much for your time today. This was truly an enlightening conversation. I hope everyone who listens to this podcast feels the same way. But just thank you so much for taking the time today.
Yeah, and thank you for having me. I mean, one of the things I didn't mention is that I know you said this a while earlier in the discussion, but that why would I focus on mesothelioma, which is a rare cancer? And I think that shouldn't matter. That we should be looking at mesothelioma and other rare cancers, because quality of life is important no matter what type of cancer you're facing.
Dr. Traeger again is with Massachusetts General Hospital, and she is leading a very innovative program that is analyzing quality of life for mesothelioma patients and lung cancer patients following their treatment. Dr. Traeger, thank you again, and thank you to everyone who has been listening.